completely. And till that, and the way to set an example, just how the second year should prepare. So we were taking final year, now taking second year also. So I will also request all the participants, all the PG students, whatever to ask in this class, it should be very relevant. We are here to discuss what are the possible questions and answers which can be asked in the Viva or long case discussion, rather than sometime what happened, the tendency is to ask a question which we always think to sometime to trouble the, the presenter. So the main theme is to ask all your doubts and queries, which can be possibly asked in the examination to all the postgraduate students. This is our just like a family discussion of a case discussion in these classes. And I think even if some questions are there which are very relevant or practical, so not just Dr. Jitesh and Dr. Vishal, they will be able to answer everything. But sometimes the questions are so much difficult, and so people are there. Very senior people are also sitting in these classes, so they will be able to answer those questions also. So from here, I request Dr. Jyotsna to take over the stage and increase stage and kindly introduce everything. Thank you, Dr. Jyotsna.
Very good evening, everyone. Thank you, sir. So as we know, perioperative diabetes mellitus is a very important topic, and the surgical population with diabetes comorbidities is very common, and they pose numerous challenges perioperatively. So that is our topic, case-based discussion today. First, we will start with Saraswati Vandana.
Saraswati Namastutyam Paradin Kamadrupini Vidyarambham Karishyami Siddhi.
So for today, our presenter is Dr. Pooja Kumari. She is a second year anesthesia student, and our moderators are from same college, Patna Medical College, Dr. Jitesh Kumar and Dr. Vishal Weber, both are assistant professors in Patna Medical College. Dr. Jitesh Kumar, he's having various
just 1 minute. Dr. Vishal Weber is the name Patna. He's a assistant professor in emergency medicine there.
Okay, sir.
Am I audible to you, Jyotsna?
Yes, sir. Is my screen visible? Okay. So we have Dr. Jitesh Kumar, Assistant Professor in Department of Anesthesiology and Critical Care, Patna Medical College and Hospital. He's having numerous publications, 12 publications to his credit, and his areas of interest are regional anesthesia and obstetrics anesthesia. Welcome, Dr. Jitesh.
Thank you, ma'am.
And then we have Dr. Vishal Weber, who is Assistant Professor in Department of Emergency Medicine in All India Institute of Medical Sciences, Patna. He is the winner of Dr. Ashok Gupta Award from Young Anaesthesiologist 2018. He is the winner of late Dr. T.N. Jha Travel Grant Award for 2013. He is a university topper of MD and MBBS, and he has 10 publications in national journals, and he is also BCLS, ACLS, and ATLS instructor. His areas of interest are emergency medicine, critical care, and trauma. Welcome, Dr. Vishal. Okay, so now I hand over to the moderators to start the session.
Dr. Vishal, please introduce Dr. Pooja.
Any problem, Dr. Jitesh? Shall I help you?
Yes. Good evening to all of you. Today, my PG student, second year PG student, Dr. Pooja Kumari, will present long case diabetes mellitus and its anesthetic management. Dr. Pooja, please share your screen.
Good evening, everyone. I am Dr. Pooja Kumari, second year resident, Patna Medical College and Hospital, Patna. I'll be presenting a case on diabetes. To begin with, let's begin the case. My patient, Ms. Sangeeta Singh, 54 years old female, housewife by occupation, is a resident of Patna, presented to the hospital with chief complaints of pain in right upper abdomen, radiating to back since 1 week, burning sensation in the epigastric region and middle of the chest since 5 days, fever since 2 days, vomiting 3 to 4 episodes since 1 day, history of presenting illness, history of pain in the right hypochondrium since 1 week. The pain was sudden in onset, severe in intensity, colicky in nature. It increased after meal, associated with nausea and vomiting. The pain was radiating to the right infrascapular area during the same time. There was history of dyspepsia since 5 days, which increased after taking fatty meal. History of intermittent fever since 2 days. It was associated with mild chills, relieved on medication with sweating. History of vomiting, 3 to 4 episodes since 1 day. Vomiting was non-projectile and the vomitus contained food particles and it was non-bilious. There was no history of yellow discoloration of eye and urine. There was no history of weight loss, no history of trauma, no history of altered bowel habit. Past history of pain in the right upper quadrant on and off since past 5 to 6 months. Patient is a known case of diabetes mellitus since 5 years. Her blood sugar level was maintained within normal range and a combination of drugs, metformin, tablet metformin 500 milligram BID and tablet vildagliptin 50 milligram BID.
Pooja, your screen is not moving. Can you make it a slideshow and make the slides moving?
Okay, sir, I'll try.
Your first slide is visible only.
Okay, sir. No problem, sir. I'll share it again.
Share it again, make a slideshow, then
Yes,
you
sir.
share it again. Huh?
Okay, sir. So is it visible now?
That's screen is being shared. Let's see. Yeah, it's fine now. You were in the past illness, history of past illness, no? Past history.
Yes, sir.
Present you have
It
already.
is stuck there only. It is not.
Yeah,
moving.
you go ahead the way you feel comfortable. Please go ahead.
So it is not moving ahead.
Just go with the arrows and with the arrows, no, you can make it. Arrows
Yes.
on the keyboard.
Yes, sir. So is it moving now?
No, it's in the same way. You do one thing. You stop sharing, then you put on the screen this slideshow.
Yes, sir.
Then you share. Then it will be easy for you.
Okay, sir. Okay, sir.
Put a slideshow now, then you share afterwards, putting the slideshow
Yes.
on.
Yes, sir. Yes.
Yes, visible. Now you can move it. If
Yes,
with
sir.
the
Is
arrow.
it
Yeah.
moving, sir?
Yeah, fine.
Okay, sir. I'll start it again.
No, the case presented done. The next page. Start with the next slide. Yeah.
History of presenting illness.
Yeah, please. Fine.
History of presenting illness. There was history of pain in the right hypochondrium since 1 week. The pain was sudden in onset. It was severe in intensity. It was colicky in nature. Pain increases after meals, associated with nausea and vomiting. Pain was radiating to the right infrascapular area during the same time. History of dyspepsia since 5 days, which increases after taking fatty meal. History of intermittent fever since 2 days, associated with mild chills, and it was relieved on medication with sweating. History of vomiting, 3 to 4 episodes since 1 day. Vomiting was non-projectile and the vomitus contained food particle and it was non-villous. There was no history of yellow discoloration of eye and urine, no history of weight loss, no history of trauma, no history of altered bowel habit. Past history, history of pain in the right upper quadrant on and off since past 5 to 6 months. Patient is a known case of diabetes mellitus since 5 years. Her blood sugar level was maintained within normal range with a combination of drugs, tablet metformin 500 mg BID and tablet vildagliptin 50 mg BID. There was no history of hypertension, tuberculosis, coronary artery disease or asthma. No history of any known allergy, blood transfusion or surgery. Family history, her both parents were diabetic. Personal history, it was normal sleep, bowel and bladder habits, no addiction. Menstrual history, menarche at 14 years of age and menopause at 50 years of age. Obstetric history, P3, L3, A0 and D0. Socioeconomic status, lower middle class family. General physical examination, patient is examined in supine position with bilateral flexed knees in a well-lit room. Patient is conscious, alert, cooperative and oriented to time, place and person. Weight 68 kilogram, height 155 centimeter and body mass index was 28.3 kg per meter squared. Vitals, pulse 130 beats per minute measured in the right radial artery. It was good in volume, normal character, normal condition of the vessel wall and all the peripheral pulses are palpable. Blood pressure 140 to 90 millimeters, 140 by 90 millimeters of mercury in right arm measured in sitting position. SpO2 98% non-Romeyer. Respiratory rate 18 breaths per minute, regular, and abdominothoracic breathing. Temperature 98.5 degree Fahrenheit. Random blood sugar level was 174 milligram per deciliter. General physical examination, pallor negative, icterus negative, cyanosis negative, clubbing negative, jugular venous pressure not raised, lymphadenopathy negative, pedal edema negative. Coming to the systemic examination, respiratory system examination. On inspection, chest appears normal, trachea appears to be in center, no suprasternal or intercostal recession, no use of accessory muscles, bilateral chest wall movement, symmetrical during respiration, no dilated veins or pulsation or swelling or scars over the chest wall. Palpation, all the findings of inspections are confirmed, trachea central in position. Chest expansion is bilaterally symmetrical. No tenderness or bony defect. Tactile vocal fremitus normal. Percussion, resonant sound in all the lung fields. Normal liver dullness in 5th, 7th and 9th intercostal space at mid-clavicular line, anterior axillary and mid-axillary lines respectively. Auscultation, bilateral equal air entry present on both the sides. Vocal resonance equal and no added sounds. Cardiovascular system examination. Inspection, precordium normal in shape, apical impulse not visible, no engorgement of superficial veins, carotid pulsations not visible. Palpation, apex beat in 5th intercostal space, 1.2 centimeter medial to left midclavicular line, no parasternal heave, no appreciable thrill or pulsation. On auscultation, S1, S2 present, no murmur. Abdominal examination. Inspection, all quadrants move well with respiration, no dilated veins. Umbilicus appear normal and inverted. On palpation, temperature raised, tenderness present in the right hypochondrium. Murphy sign positive. Guarding and rigidity negative. No mass or no organomegaly. Hernial orifices normal. Percussion, tympanic node present, no shifting dullness or fluid thrill. Auscultation, bowel sounds present. Central nervous system examination. patient conscious, oriented to time, place, and person. Higher mental function with a normal limit. Cranial nerve examination with a normal limit. Speech normal. No sensory or motor deficit. Tone normal. Power bilateral upper limb 515, bilateral lower limb 515. Reflexes bilateral upper limb and lower limb deep tendon reflexes normal. Spine examination, normal curvature of spine, no deformity present, intervertebral spaces well felt on palpation. Airway examination, done in sitting position. There were no visible craniofacial deformity. Both nails look normal. Mouth opening is 5 centimeter. Modified Mallampati classification is grade 2. No buck teeth, no loose or missing teeth or artificial dentures. Chiromental distance was 7 centimeter. Higher mental distance was 6.5 centimeter. Sternomental distance is 13 centimeter. Neck range of motion is adequate. Neck circumference is 38 centimeter at the level of thyroid cartilage. Upper lip bite test is grade 1. Prayer sign is normal. And palm print test is grade 0. Provisional diagnosis, 54-year-old female of ASA grade 2, known case of well-controlled diabetes mellitus on medication, is a case of acute calculus cholecystitis.
So, Pooja, am I audible to you?
Yes, sir.
Okay, fine.
Yes,
Well,
you're audible.
okay. So this is a case of clear-cut diabetes you are having.
Yes, sir.
So she's on controlled diabetes mellitus she's having,
Yes.
and she is posted for acute calculus cholecystitis. So she will be posted for elective cholecystectomy.
Yes, sir.
So how do you proceed for this evaluation of the case? I mean to see, say, what would you investigations you would order in the PAC clinic when
Yes.
the patient comes, and how
Yes.
would you proceed for the management of this case?
Yes, sir. So basically, this is a well-controlled diabetes. My patient is well-controlled on diabetes. So in the PAC, I will first take the detailed history of the disease of diabetes, the onset, the duration, the drug history of the patient, on what drug the patient is on, since when, what is the dosage of the drug. Then I'll take the history of any complication of the disease for microvascular or macrovascular complications. Then I'll order routine investigations of complete blood count, WBC count, then chest X-ray, ECG, echo, then renal function test, liver
Can
function
you
test.
just show me the first few slides of your case, because
Yes.
somehow I missed it.
Yes, sir.
The
Yes.
first few slides of the case.
Yes, sir. Sure.
Yes, please change.
Yes, sir.
Okay, fine. Next. Okay, fine. So what medication the patient is on right now?
So the patient is on metformin, tablet metformin 500 milligram BID and tablet vildagliptin 50 milligram BID.
Okay, okay, fine. So proceed.
So
So
then
you-
I'll order the basic investigations, and I'll also order HbA1c to know the sugar control
Okay,
since the past and
what investigations would you send for?
so I'll order complete blood count
Okay.
to check for anemia or then infection. WBC count will tell the infection. Then so coagulation profile, blood coagulation profile, then chest X-ray, ECG, echo, renal function test, liver function test, serum electrolyte, HbA1c level,
Okay,
then
okay, fine.
Yes,
So
sir.
you have ordered all the investigations,
yes, sir.
and supposing you got an HbA1c of 7.1.
Yes, sir.
The patient was on metformin 500 milligram and vildagliptin, na?
Yes, sir.
So, okay, fine. So, the HbA1c is 7.1. The fasting blood sugar is, say, for example, 140. The postprandial is, say, for example, 145.
Yes, sir.
So, do you think it is adequately controlled?
Yes, sir. The patient is adequately controlled. If the HbA1c level is less than 8.5, the patient can be easily posted for the elective surgery. It is said as well controlled, and we can post it.
So are you not worried about the fasting blood sugar of
So
140?
we are worried about the fasting. The fasting guideline says that it should be between 140, 110 to 140, and the postprandial should be between 140 to 180.
So how do you evaluate this case, having done the investigations?
Sir, how will I evaluate the patient?
Yes.
So I'll order the basic investigation as I said earlier.
Yeah, you have done that.
Then I'll go with the airway examination
Okay.
to check for any complication, for slip joint syndrome, or for seeing that if there is any rigidity in the joint. I'll make the patient do the palm print test and the prayer sign.
Which joints you want to evaluate in this patient?
So basically, I want to evaluate 3 joints: temporomandibular joint, atlanto-occipital joint, and cervical spine, because these are mainly involved, and that is of my concern, because there will be difficulty in laryngoscopy and intubation. So I want to anticipate prior only whether it will be a difficult intubation or an easy intubation. So then also I'll
Can you tell me why are you worried about the stiffness of these joints particularly?
so because there will be difficulty in intubation and laryngoscopy.
Okay, fine.
Yes, sir.
So what is the grading of palm print test?
So palm print test, in this, the grading is, there are 4 grades: grade 0, grade 1, grade 2, grade 3. Grade 0, all the palm, the whole palm gets printed on the paper. Grade 1, the 4th and 5th interphalangeal joints are missing. Grade 2, the 2 to 5th interphalangeal joints are missing. And in grade 3, only the tip is visible. Only the fingertip is visible.
Dr. Pooja, have you examined patient for any autonomic neuropathy? Your
Yes,
patient
sir,
is
I will
suffering from-
examine my patient for diabetic autonomic neuropathy, because it is of concern, as there will be severe hypotension in the patient intraoperatively also. And my patient there will be also, I will examine the patient for any peripheral neuropathy associated with diabetes.
Regarding that stiffness of the joints,
Yes,
there is
sir.
a term called sclerodema of diabetes. What is that?
Sorry, sir.
Sclerodema of diabetes. There is a term.
Yes, sir.
What is sclerodema of diabetes? Do you know of that?
No, sir.
Actually, it is a non-pitting edema of the neck and the back.
Yes, sir.
So that can also pose difficulty besides the normal stiffness of the temporomandibular and the atlanto-occipital joints, which you are saying. There
Yes.
can be non-pitting edema of the neck and the back also.
Yes, sir.
That can pose also a difficulty during intubation.
Yes, sir.
Okay, fine.
Yes.
Okay, what about the assessment of diabetic autonomic neuropathy?
So there are tests for diabetic autonomic neuropathy is basically tested based on the sympathetic. There are sympathetic tests for it, and there are tests for parasympathetic system. In sympathetic system, we test.
Before going on to the tests directly, can there be signs and symptoms which can elicit actually diabetic autonomic neuropathy in the patient?
Yes, sir.
You can ask from the history itself. No?
Yes, sir. It involves multiple system.
Yeah.
In cardiovascular system, the patient will present with tachycardia, exercise intolerance, orthostatic hypotension. Then in respiratory system, in GIT, there will be regurgitation, there will be constipation, diarrhea, there will be gastroparesis will be seen, dysphagia will be seen.
Okay, fine. So now, how do you evaluate if you get any of these signs? How do you evaluate the whether diabetic autonomic neuropathy is present or not? What are the tests? I mean to say.
So there will be test for sympathetic system, in which there will be we'll check the heart rate response to standing. Sorry, heart rate response to Valsalva maneuver.
Okay.
Then heart rate response to respiration.
Okay.
Matlab deep breathing. Then Valsalva maneuver and
Okay, this is the test for the parasympathetic involvement. What are the tests for sympathetic involvement?
The test for sympathetic involvement is heart rate variability. We'll check for heart rate variability in the patient, which is done by telling the patient to inhale deeply at a rate of 6 breaths per minute. If the patient, if there is a the heart rate increases on deep breathing. Sorry, basically there is respiratory sinus arrhythmia, which is normally due to vagal stimulation to the SA node. In cases of diabetic autonomic neuropathy, respiratory sinus arrhythmia is altered. So we'll check for that, telling the patient that take a deep breath and quiet breathing at 6 breaths per minute. And if the heart rate variability is less than 10 beats per minute, it is of significance for us. Then also we'll check for Valsalva manual, in which Valsalva is basically for parasympathetic control, in which we'll check for Valsalva ratio. Valsalva ratio, the patient lies supine, and we'll tell the patient to deeply expirate with forceful expiration will be said to done, and at the fixed resistance of 40 millimeters of mercury for 15 seconds. There are 4 phases which are noted: phase 1, phase 2, phase 3, phase 4. Initially, there is a increase in BP followed by decrease in heart rate. In phase 2, there is fall in BP followed by increase in BP, and a reflex tachycardia is seen.
Okay, Dr. Pooja, I'll interrupt because we have a short span of time. I don't think we'll be able to cover everything about all the tests. Yes, and there are questions coming up. So, okay, fine. You have ruled out diabetic autonomic neuropathy and all that. What microvascular and macrovascular changes do you expect, and why should you be worried about? Just a brief outline about what are the changes which can occur in these patients. So accordingly, you as for example, you said the ECG, you said about sending for KFT, LFT, all the baseline investigations you have asked about, also the serum electrolytes. Why are you so much worried about all these things, and why do you need to get these investigations done?
Yes, sir.
So what are the microvascular and macrovascular changes you are getting in this patient?
Yes, sir. So the microvascular complications can be, patient can present with coronary artery disease, peripheral arterial diseases. So and the macrovascular diseases can be diabetic neuropathy, nephropathy, diabetic nephropathy. Then microvascular also involves diabetic retinopathy. So we will check prior only for these complications in the patient. So the investigation I am ordering will check these complications.
So let's say having done all the investigations, how would you proceed for the pre-operative management of this case? What orders you will give in the pre-op period, and how will you manage this case in the entire scenario? Say, for example, the in pre-op, intra-op, and the post-op.
Yes, sir. So pre-operatively, as I already told the investigations, I'll order the same investigation. I'll go with the airway examination of the patient. I'll do the test for diabetic autonomic neuropathy. I'll check for any complication of diabetes in the patient. I'll regarding the drug the patient is taking, I'll withhold the metformin on the day of this night, a day before the surgery, night before the surgery, and on the day of the surgery. And the vildagliptin can be continued. And I'll switch the patient to GKI regimen. And for fasting, 8 hours of fasting is required for the patient. And I'll advise injection metoclopramide 10 milligram night before the surgery, and on the day of the surgery, 1 hour prior to the surgery. Injection ranitidine IV 50 milligram night before the surgery and 1 hour prior to the surgery. And the tablet alprazolam 0.25 milligram can be given night before the surgery. Also, the patient should be posted first in the OT list to reduce the fasting period of the patient. then on in the OT, I'll first of all, I'll order serum electrolyte and blood sugar, baseline blood sugar level of the fasting baseline blood sugar level of the patient. 2 wide bore cannulas will be made sure first. Then the patient will be attached with the baseline monitors, and the baseline value should be checked for blood pressure, SpO2, heart rate, then capnography, temperature, all the baseline parameters will be noted. Then I'll induce the patient with the induction will be done with injection fentanyl, 100 microgram according to the dose, and injection propofol, 100 milligram IV. The patient muscle relaxant, we can use vicuronium. As in my setup, vicuronium is available. I'll go with vicuronium, 5 milligram. And then after proper pre-oxygenation and giving these injections, I'll intubate the patient. I'll check for bilateral equal air entry, and I'll fix the tube and I'll connect it to the ventilator. Intraoperatively, hourly, we'll check for hourly blood sugar level so that I can manage any alteration in the blood sugar level intraoperatively.
Well, there has been a question raised by one of the audience, and he is asking, how will you manage intraoperatively high blood glucose levels?
Yes, sir. If the blood sugar level goes, if the blood sugar level increases intraoperatively, I can switch to GKI regimen, in which.
What is GKI regimen? Will it take care of the high blood glucose levels intraoperatively?
So I can, if the blood sugar level is more than 250 milligram, I can give bolus of insulin, 10 to 20 international unit. Then I can go with, later on, I can switch it to infusion at 1 units per hour, 1 to 2 units per hour, depending, titrating the blood sugar level accordingly.
Yeah, actually, you need to give a bolus insulin, and also at the same time, you can give a basal insulin infusion at the same time to take care of the high blood glucose levels.
Yes, sir.
Okay.
Is there any?
One thing I think you have missed on, and that was did you order for a pre-op investigation on the day of surgery?
Yes, sir.
What was that?
So that was baseline fasting blood sugar level and serum electrolytes.
Okay, fine.
Yes.
Go ahead.
So then intraoperatively, I'll manage the patient with oxygen nitrous oxide and sevoflurane, and intermittent muscle relaxant can be given. And with as the surgery will complete, I'll the reversal will be done with the usual 2.5 milligram of neostigmine with 0.5 milligram of glycopyrrolate, and in the PACU post anesthesia care unit, we can continue with the same GKI regimen to the patient, and the patient will be switched to oral hypoglycemic agent once the patient is allowed to eat orally. And 2 hours after that, we'll stop the infusion.
Okay, there has been also one question that 1 unit of insulin will decrease the blood sugar to how much level?
So it will decrease to about 30 milligram per deciliter.
So it is actually even 25 to 40.
25 to 40.
Yeah.
Yes,
and also there was one question regarding what's your plan for unexpected difficult intubation. Well, airway management is not a part of this. If you go into the airway management, it will be difficult to tackle the entire topic. So I'll answer it separately. But then again, yes, that is correct. If you have to talk about 1 unit of glucose lowering the blood sugar levels, it is 25 to 40. So on average, it is 30.
Yes.
There is another question. What is the target blood glucose level intraoperatively and postoperatively?
Yeah. So intraoperatively, the blood sugar level should be maintained between 140 to 180 milligram per deciliter, and postoperatively, it should be in the same range, 140 to 180.
Are there any condition in which you want to control tight control?
Yes, sir. There are few conditions in which we need tight sugar control of blood sugar level between 70 to 110 milligram per deciliter, like in cardiac surgeries, in pregnant patients, in patients on transplant surgeries, burn patients, and also in neurosurgery, in certain neurosurgical cases.
Okay. And
Okay.
what about the choice of intravenous fluid you want to go for?
Sir, there is no such guideline that we should switch. We should select any one, but mostly half normal saline, 0.45% normal saline, or normal saline is preferred. But there are both have advantage and disadvantage. Our ringer lactate and normal saline both have advantage and disadvantage.
So why don't you go for Ringer's lactate?
So ringer lactate can cause hyperglycemia in these patients, as the lactate will be used for gluconeogenesis in the liver.
And what about going for normal saline? That can also cause hyperchloremic acidosis.
Yes, sir. That can also cause hyperchloremic, but it is said there is no such guideline, sir. We can choose anyone.
Okay, fine.
Not such.
Then any other option do you think of besides Ringer lactate and normal saline?
So we can go for balanced salt solution.
Yeah, exactly.
Yes, sir.
Okay, fine. And what about the induction agent? You mentioned that propofol to be used as an induction agent.
Yes, sir.
What about using ketamine or etomidate?
So ketamine causes hyperglycemia. So
that should be avoided.
It should be avoided. And etomidate is good for cardiovascular concern. It can be used, and but in our setup, propofol is a good option. The patients are more comfortable with propofol, so we are more comfortable with propofol. So I'll induce my patient with propofol.
Okay, but then again, if you have an option of using etomidate, that can be the drug of choice.
Yes, sir, that is the drug of choice.
Okay. If you are using the Ringer lactate,
yes, sir.
Then after how much time it will increase the glucose level?
Sir, gluconeogenesis will take almost an hour. So
no. RL will increase blood glucose level after 24 to 48 hours of infusion. There is no instant hyperglycemia, but there will be hyperglycemia in post-operative period. So that's why we usually avoid Ringer lactate.
Yes.
Intraoperative, you will not get that hyperglycemia because of the RL. Yes, but in the post-op period, within 24 hours, you will be getting hyperglycemia in spite of giving the adequate dose of insulin. And there has also been a question that ranitidine in pre-medication instead, can't we use pantoprazole?
So pantoprazole, we basically use H2 blocker because that is seen to have a better sphincter, better action on the sphincters. That's why.
So what are the current concerns regarding ranitidine?
So ranitidine is known to be carcinogenic. Recently, it has been
exactly.
Current concern is we usually don't give ranitidine now.
Yes, sir.
Yeah. Only metoclopramide is.
It is avoided. It is avoided. Yes.
Is indicated.
It would be better you go for a pantoprazole, no?
Yes.
Okay. Pooja, there is another case. A 30-year female posted for emergency LSCS for fetal distress.
Yes, sir.
At approx 2 a.m.
Yes, sir.
She is a known case of diabetes mellitus and is on insulin galargine 20 unit subcutaneous in night and 16 unit NPH insulin in morning. At present, her blood sugar is 200 milligram per deciliter.
Yes, sir.
And she was diabetic since last 4 years. How you will manage this case?
Sir, first of all, when the patient will arrive, I will take a detailed history of the patient, regarding the complications of diabetes, regarding the same history of diabetes since when the patient is having the disease, the family history of the disease. Also, I will order serum electrolytes for this patient. Prior taking, I'll do the airway examination of the patient preoperatively. Then in the OT, I'll do the same. I'll make sure that there are 2 wide bore cannulas. The patient has 2 wide bore cannulas, and the baseline values of the vitals will be taken in the same way I did earlier for pulse for saturation, heart rate, temperature, then blood pressure, non-invasive blood pressure. Then my mode of anesthesia in this patient will be spinal anesthesia, regional anesthesia basically. So I'll check for the spine. For the spine examination will also be done preoperatively, and preoperatively I'll advise the patient for prophylaxis regarding aspiration.
Okay.
Injection.
Her blood sugar is 210 milligram per deciliter.
Yes, sir.
How you will manage the hyperglycemia preoperatively, intraoperatively?
Sir,
Because there is no time to withhold the insulin regimen.
yes, sir.
This is an emergency case.
So
How you will manage?
as the patient is this patient is pregnant, I'll go for tight sugar control regimen in this patient. I'll order 5% dextrose. The tight sugar regimen is blood sugar level of the patient upon 150. As in this patient, it is almost 210. So there will be I'll 50 is 2.3. It's almost 1.5 units per hour will be the rate of insulin in this patient. So I'll in 50 ml of syringe, 50 ml of NS, I'll add 50 ml of 50 units of insulin. I'll make it 1 unit per ml of insulin, and I'll set it at a rate of 1.5 ml per hour to maintain the blood sugar level between 70 to 110 milligram per dl.
Okay. Would you like to give 5% dextrose or 10% dextrose in this patient?
Sir, I'll give 5% dextrose as a maintenance, because the insulin will also decrease. The insulin can also cause hypoglycemia.
Okay. So hypoglycemia is a concern in anesthetized patient. In if patient is conscious, there will be some sign and symptoms.
Yes, sir.
But if patient is anesthetized,
Yes,
how you will judge there is hypoglycemia? How you will decide there is hypoglycemia?
Yes, sir. So as you said, if the patient is not anesthetized, we can get the symptoms of the hypoglycemia. Like there will be tremors, there will be tachycardia, there will be sweating. There will be signs. But if the patient is anesthetized, it is almost impossible to know. So there should be a high degree of suspicion regarding the same. We can go for blood sugar level check. We can check the blood sugar level, and if it is less than 70, if it is less than 70 milligram per deciliter, then we can suspect there is hypoglycemia in the patient. Also, there will be hypotension in some patients. So we'll manage this patient with bolus injection of 50% dextrose, 25 ml if the patient is conscious. So as this patient is not conscious, we'll give a bolus of 50 ml of 50% dextrose. And then later on, we'll maintain the patient on IV insulin infusion at 1 unit per hour with dextrose, 10% dextrose.
Okay.
The target our target for switching to insulin will be more if the blood sugar level goes more than 100 milligram per deciliter.
Okay. What is the criteria for stopping and restarting the insulin?
Sir,
Competitively and
stopping and restarting insulin. Sir, if for stopping, if we are posting the patient for elective surgeries, so if the patient is on an NPH insulin and regular insulin, the dose of NPH insulin should be 2/3. Both NPH and regular insulin should be 2/3 on the night before the surgery, and it should be half the dose should be given on the morning of the surgery. If the patient is on some insulin infusion, then we should decrease the dose to 30% night before the surgery, and on the morning of the surgery, patient can be continued at with the same IV infusion at the basal basal rate. Or we can also switch the patient to Glargine and decrease the stop the insulin infusion 60 to 90 minutes later on. Or IV infusion drip, IV infusion insulin drip can be set at a basal rate. If the patient is on a combination of longer acting and a short acting, the longer acting should be done 2/3 of the dose a night before the surgery, and the short acting dose can be given, and on the morning of the surgery all the doses should be stopped. This is for stopping the insulin. And regarding starting the insulin again, if we are switching the patient to some oral hypoglycemic agent, so if the patient is on solid diet, we can advise, the patient is taking solid diet, we can advise oral hypoglycemic agent, and the IV insulin should be stopped 2 hours after that. There should be an overlap of 2 hours. And if the patient is on liquid diet, we should continue with the insulin infusion because it won't it won't cause that hypoglycemia.
There will be variability of blood glucose level.
Yes, sir, there will be variability of blood glucose level. So we will continue with the IV infusion in liquid diet patient.
So there is a question, what is DK and how you will manage this case?
Say, for example, your patient in the post-op period has landed in DKA.
Yes, sir.
So,
DKA is diabetic ketoacidosis. It is mainly seen in type 1 diabetes mellitus patient. And in this, there is we can see there is hyperglycemia of more than 300 milligram per deciliter. There is presence of ketone bodies. So there will be ketonuria and there will be ketonemia. There will be metabolic acidosis. The pH will be less than 7.3, typically less than 7.3. Bicarb concentration will be less than equal to 15 milliequivalents per deciliter, and the osmolarity will be less than 300 milliosmoles per liter. And we'll manage this. My patient will be drowsy. It will have tachycardia, hypotension, seizures. Then regarding managing the patient, I'll first of all, the main concern, the patient will be dehydrated. So I will go with fluid resuscitation in this patient. So the fluid of choice will be half NS or half normal saline or normal saline at the rate of 15 to 20 ml per hour. In the first 4 hours, my rate will be 50 to 20 ml per hour. In the next, in the first hour, the rate will be 15 to 20 ml per kg per hour. In the next 4 hours, this rate will be halved, and the fluid correction will be done over the 24 hours. Next is I will give insulin to the patient. First of all, depending upon the hyperglycemia, I will give 10 to 20 units of bolus insulin, and later on, insulin infusion will be followed at the rate of 1 unit per hour, or it can be 0.1 unit per kg per hour. Then bicarbonate will be given only if there is severe acidosis, that is the pH is less than 7.0 milliequivalents per liter. We can also advise potassium depending on the serum electrolyte, on the potassium concentration. but it is not indicated if the potassium is more than 5.5 milliequivalents per deciliter. And if the potassium is less than 3.5 milliequivalents per deciliter, potassium should be given first, then insulin should be started. Otherwise, it will lead to more hypokalemia in this patient. And phosphate can be given depending upon the concentration of the phosphate checked prior. And that's it, sir.
And
Okay.
sir,
When-
so how do you
When you
target-
will,
okay, Dr. Jitesh, I was just asking how do you target? What should be the rate of lowering of the blood glucose, or say for the bicarbonates?
Yes, sir. So my rate should not be more than 50 milligram per deciliter per hour
Okay,
for glucose correction. And for bicarb correction, it should not be more than 5 to 10 milliequivalents per kg.
okay. What about the ketones?
So ketones, yeah, we should check for ketone body. The nitroprusside test is not as good as this, because it will only check for acetoacetate and acetone ketone bodies. The main culprit over here is beta hydroxybutyrate, which is ultimately converted to acetoacetic acid. So if we are checking the patient with nitroprusside test, it will appear as if the decay has worsened. The ketone bodies are increasing. So we should check for beta hydroxybutyrate in this patient instead of nitroprusside test.
Dr.
okay,
Jitesh?
when you will start 5% dextrose in DKA patient?
Sir, we will start with 5% dextrose in these patients. Once the sugar level is sugar level goes more than when the sugar level is less than 200.
250.
Yes, sir, 250.
So there has been one question that can injection glargine be used intraoperatively?
Sir, injection glargine, use of injection glargine intraoperatively is very risky, because it will lead to hypoglycemia in this patient.
When?
The duration of action for glargine is 1 to 2 hours. Onset of action is 1 to 2 hours. So if the surgery continues for more than 2 hours, there is chance of hypoglycemia in this patient. So
That hypoglycemia will usually manifest in the post-op period when the patient is still NPO.
yes, sir.
It's a long-acting insulin. So glargine is not advocated intraoperatively.
Intraoperatively, we should go for some shorter acting
Yes.
options. Yes, sir.
Exactly. And if you are using insulin frequently, chances of hypoglycemia to the baby, is it there?
Yes, sir. There are chances of hypoglycemia to the baby. So we should maintain, that's what I said, we should maintain the tight sugar control in these patients between 70 to 110 milligram per deciliter in pregnant patient. And there is a chance of neonatal hypoglycemia in this patient. So as the baby is delivered, we should advise early feeding of the baby, and with, if possible, as soon as possible, or at max within 30 minutes, we should check for the blood sugar level of these babies. If it is it should be more than 36 milligram per deciliter. If it is less than that, we should initiate the babies on tube feeding or dextrose.
Dextrose solution should be given.
Exactly.
Dextrose solution should be given.
You said we should stop metformin the day before surgery. This patient,
Yes, sir.
not talking about this patient, actually there has been a question raised. Can
Yes.
oral vildagliptin can be given the night before surgery?
Yes, oral vildagliptin can be given the night before the surgery.
So just tell me about which oral hypoglycemic to be stopped when.
Yes, sir. Sir, sulfonylureas should be stopped a day before the surgery. And metformin should be stopped a day before the surgery. Metformin is basically belongs to bigger nights. And thiazolide ions should be stopped. Only group of drug with DPP-4 inhibitors can be continued. Rest all should be omitted.
Like thiazolidine, say for example, pioglitazone.
Pioglitazone and rosiglitazone.
So if you're using that, you can actually continue till the day of surgery. Some even advocate that, but it should be like a short duration surgery and the patient should be allowed to resume the normal diet.
Yes, sir.
So then you can continue with that.
Yes, sir.
Dr. Josna, Dr. Madhuri want to say something?
Yes, sir.
Unmute.
Yes, sir. I unmute.
Regarding that vildagliptin is a DPP-4 inhibitor,
Yes, sir.
and the trend was to omit it before
Yes.
surgery.
Yes,
But nowadays there is evidence, and they say that you can give it, you can
Yes, ma'am.
continue because of the low risk of hypotension.
Yes, ma'am.
So there is one, the AGBI, they recommend giving continuing DPP-4 inhibitor even on the day of surgery because the risk of hypotension and all is low.
Yes, ma'am.
Exactly.
Pooja, you can stop
Doc-
sharing the screen. Pooja,
Yes, yes, sir.
stop sharing the screen so that gallery view should be there. People can ask the question. No?
Yes, sir.
I'm just enabling everybody to.
One-
Pooja,
There is one more
if
question. There is one more question in the chat box. How many hours NPM after surgery?
How many hours NP after surgery? That depends on the
NPO.
peristalsis when it comes. Once the peristalsis come, we can advise oral feeding. But if the patient was prior on oral hypoglycemic agent, we'll only advise oral hypoglycemic agents once the patient resumes to solid food. Not on liquid diet, only on solid food. Once the peristalsis comes in the patient.
Okay.
Yes.
Pooja, if there is renal or liver dysfunction, what will be the dose of insulin? It will be more or less?
Sir, if there is renal or liver dysfunction, the dose of insulin will be decreased.
Right. Because insulin metabolism depends upon the liver and metabolized on liver and renal functions. That's why if usual dose, if you will give usual dose, there will be chance of hypoglycemia. So we decrease the insulin dose in patient of liver and renal dysfunction.
Okay, sir.
Dr. Naveen, you want to say something?
Yeah, it was regarding the diabetic acidosis. Pooja, first of all, to be honest, lots of congratulations to you. You have been having all the barrages, and I'll take this opportunity to request Dr. Bajwa. We can have two students because there are two chairpersons and two examiners. So one can take a long case, and so, like in this scenario, diabetic acidosis could have been taken by the second because she has been taking the questions so nicely throughout the last 1.5 hours or so. So, Pooja, diabetic acidosis, you were mentioning about some tests, this should be done, that should be done. Practically,
Yes.
what are you doing it?
So sorry, practically.
What are you measuring? Urine for ketone bodies or something else?
So I'm looking for the blood sugar level and the ketone bodies, and
Ketone bodies in the urine, na?
in the urine, and I am more concerned about washing the ketone bodies from the body.
Now, suppose you managed your case very well, and after 4 to 5 hours of your efforts of fluid resuscitation, starting the normal saline, decreasing the blood sugar at the desired rate per hour, correcting the metabolic acidosis, starting the potassium in due course of time, and after your 4 hours of efforts, now the pH is 7.35, blood sugar is 200. Your neutralizing drip is going on, 5% dextrose with the 12 units of regular insulin. Your potassium is 4. The breath order has corrected. VP is 120/70. Heart rate is 84. Saturation is normal. And the surgeon wants to go for, say, above knee amputation. But urine for ketone bodies, which were earlier 3+, now they are 2+. So what will you do?
Sir, if the ketone bodies, urine for ketone bodies is 2+, I'll defer the surgery for more time. And
now that is the catch, because see, this patient usually which are coming for amputations are patients who are having gangrenous thing.
yes, sir.
So they land up in septicemia, and sepsis will further cause insulin resistance, again lead on to hyperglycemia, again patient will go into chances of going into diabetic ketoacidosis.
Yes, sir.
So see, beta, it takes around 24 hours
Hmm.
for urine for ketone bodies to disappear at the earliest.
Yes, sir.
So once the urine for ketone bodies are in declining trend,
Yes, sir.
and the amputation has been planned, usually in diabetic patients, is because of the gangrene only.
Yes,
So
sir.
we can take up this patient for emergency surgery so that sepsis can be taken care.
Yes, sir.
Then comes the next question. Okay, fine. So you won't defer the surgery. You have
Yes.
optimized the patient. You would have deferred in the first place when your pH was 7.1 or less than 7, like that, and your sugars were 400, 500. Patient was hypoglycemic. The sodium, the electrolytes were in disarray, and the patient was hemodynamically unstable. But after your 4 hours of active resuscitation, now patient is hemodynamically stable with better biochemical profile. So it is better to take up the patient and don't wait for urine for ketone bodies to disappear.
Okay, sir.
If there is a declining trend, we can take up the patient.
Yeah.
Secondly, the thing is, which type of anesthesia will you prefer?
Sir, in these patients, we'll prefer general anesthesia. As the patient,
No, see, you know, these are diabetic patients with gastroparesis, above knee amputation. See, you can document the neurological deficit.
so if
And,
possible, we'll go with some regional block.
No, tell me which regional block. It's a half an hour, 45-minute surgery.
Yes,
So
sir.
what will you like to do?
Sir, I'll go with femoral nerve block.
See, one straight away from GA, you're shifting to femoral nerve block.
So
So that's
because
why
there
see, yes, you're right in the sense. See, there are different options. You can use unilateral spinal anesthesia also.
Yes, sir.
You can use spinal anesthesia also, low dose. You can use nerve blocks also. But if
Yes.
you're using nerve blocks, you have to clear-cut document whether there is any other pre-existing
Prior
neuropathy or not,
Yes, sir.
and whatever the neuropathic, so that for medical legal things, right?
Yes. Yes, sir.
So what now, if you give a nerve block, what
Yes.
happens to those of local anesthetics?
So the dose of local anesthetic decreases.
Why? Good.
Because the nerves are already less sensitized.
Okay, and any other reason?
So no, no, sir.
Dr. Madhuri has raised hand. Go ahead, Dr. Madhuri.
Pooja,
Yes, ma'am.
what are the advantages of regional anesthesia in a diabetic patient?
Yes, ma'am.
I think any case of diabetes which you get, the first thing your anesthesia technique you should try is regional only.
Regional anesthesia.
General anesthesia you should never tell unless and until it is mandatory. Like for example, your previous case of cholecystectomy, it was okay, you told GA. But
Yes,
for a case of diabetic foot, it has to be regional only.
okay.
So tell me, this is a very common question asked by examiners. What are the advantages of regional block in diabetes patient?
Yes, ma'am.
Tell me
Ma'am,
one thing.
if we give regional anesthesia to the patient, the response to hyperglycemia will be preserved in these patients.
Okay.
Then
Next.
the stress hormone which are released during general anesthesia like cortisol,
Will
noradrenaline
be less.
will
Okay.
be
Next.
less.
Next.
Then signs of hypoglycemia or hyperglycemia can be easily seen in this patient. As these
That you
patients
have
are-
already told me. Next.
Yes. Then there will be better NPO status. There will be better outcome of the patient. Prognosis will be better. Also, we can easily switch the patient to normal diet early as
Okay.
compared to the
Done. Anything else?
Ma'am.
What about the most important, the stress, you will not be interfering with the airway.
Yes,
You will not be
the
interfering with
complication
the
is
airway.
related to difficult intubation.
Yes, then the blood loss will be less.
Blood sugar.
Why are you scared of blood loss in diabetics? What is the problem of blood loss in diabetics?
Diabetic patients are already anemic and they are also there is a hypercoagulable state.
No.
The patient.
Why it is like that?
They are already they have hypotension. They are dehydrated already. So we should maintain the blood pressure.
No, because of the autonomic neuropathy, they are not able to respond to the hypotension or to the blood loss. Like a normal patient would have responded by an increase in the heart rate. which is not possible in a patient with diabetes because of autonomic neuropathy, right? Then the chances of deep vein thrombosis will be less, correct?
Yes, ma'am.
And the most important is the stress response to surgery will be less. So the rise in blood sugars will be less.
Will be less.
So because of all these reasons, you have to go in for regional only. Better to go in for regional.
Yes,
I
ma'am.
have one question for you, Pooja. In your previous case, which you told cholecystectomy,
Yes, ma'am.
you have not given anything for anxiolysis to the patient
So, ma'am, I
pre-operatively.
had given preoperatively tablet alprazolam 0.25
Okay.
milligram.
Anything
before
else
the-
you gave on the day of surgery?
I can give the same with a sip of water, tablet alprazolam, just 1 hour before the surgery.
Or you can give intravenous midazolam also.
Yeah.
Okay,
I
so
think that's
my point for telling you this is anxiolysis is very important because
Yes,
again it leads to the stress response. And what about the role of clonidine and dexmedetomidine in these cases? Nowadays we have no dexmed and all.
Yes,
We're
ma'am.
using it everywhere.
Yes,
So
ma'am.
any role here for this case? I'm not asking you in the pregnant diabetic. This is in this non-pregnant diabetic taken for cholecystectomy.
No, ma'am.
Can you give it to reduce the stress response? You can give IV dexmedetomidine, you can give oral clonidine before surgery or even IV clonidine. Okay.
Yes, ma'am.
And suppose I ask you one question that will you intubate or will you use a supraglottic airway device? Because you want to reduce the stress response, no?
Yes, ma'am.
So which one, how will you secure the airway?
Ma'am, I'll go with
Suppose I
intubation.
tell, no?
I'll go with intubation because there will
Why?
be chances of aspiration in these patients.
Mhm.
There can be gastroparesis also prior.
So what, I can even use a Procel LMA. It has also got, it will also protect the airway.
Ma'am, but still,
Cholecystectomy will be not a very long duration surgery, around 1 hour or so.
yes,
An
ma'am.
expert surgeon can finish it.
Ma'am, but
Why
still,
not?
but still there is a chance of aspiration with these devices. So I'll
Even
anytime
with second generation devices, you mean to say there will be, you have,
there will
there's a
be
chance of aspiration.
there will
Okay,
be
ठीक है. No, you can answer in any way. You can use. It's not that you cannot use, but
Yes, ma'am.
if you want to stick to your answer, you stick. And one more thing is, why do you want to play around with the sugars? For a, can you go? What about your take on no glucose, no insulin regime? Suppose a surgeon is a very expert surgeon, and within 1 hour the gallbladder is out and surgery is over. Will you still go in for the GIK regime? The sugar is well controlled.
Yes, ma'am.
She is a well-controlled diabetic. She doesn't have any comorbidities, nothing. Then do you want to play around with the sugars and put insulin, all these things, and then patient will develop hypoglycemia and so many things. So what is your take on that? Like,
Ma'am, I will continue with the GKI regimen in the post-op period also till the patient switches.
I'm not asking you post-op. I'm asking you intraoperatively.
Intraoperatively also, ma'am. To maintain the blood sugar level in the normal range, I will switch to the GKI regimen.
Even in a short duration surgery?
No, ma'am. Not advised in a short duration surgery until and unless the patient blood sugar level remains within the normal range. It is not advocated.
Suppose your patient is a case of IDDM and she has got an insulin pump.
Yes, ma'am.
You know, nowadays insulin pump, patients are coming with insulin pump.
Yes, ma'am.
And she has come to you for elective cholecystectomy, this patient.
Yes, ma'am.
Tell me how you will manage.
Ma'am, I'll decrease the dose of the infusion to 30%.
First of all, tell me something about insulin pumps. I think our audience may not be, everybody will not be knowing about the insulin pumps. How many times have you anesthetized a case with an insulin pump? Not many. So just tell me what is an insulin pump and what are the types of pumps. And if you get a patient with an insulin pump, how you're going to manage the case?
Ma'am, I'm not much aware about the types of insulin pump.
Good.
Okay.
Good. I like this answer because, don't put any blunder in the answering. Then pumps or insulin pens, everything is available nowadays. Yes. But if you make a blunder, it will not be tolerated for the final marks. That's a good answer.
Yes. So, but about
Dr. Madhuri will tell only briefly about the insulin pumps.
Yes.
Yeah. So I just asked you this question because you are doing very well. And then to just give you some more marks, definitely the examiner can ask you these questions and you are a new generation anesthesiologist. definitely you're going to encounter such cases.
Yes.
Okay, so the insulin pump, it's a new a new technology, and if you there are two types of insulin pumps. Basically, the insulin pump has got there is a pump which is and an IV cannula which is that will be inserted as a patch, okay, in the skin, subcutaneous, and then there will be a outside device which is worn by the patient, that is the control.
Yes.
Okay, so these insulin pumps, just like the pacemaker devices, no, so they will be manufactured by different companies and different makes. So when you get a patient with an insulin pump, basically you have to take a written consent from the patient that you can use this pump perioperatively. Okay, then you have to find out how this pump is working and make a clear plan of how to use the pump in case a patient develops hypo or hyperglycemia intraoperative, right? So we should know how to use that pump.
Yes.
So you have to get in touch with the manufacturer and with the endocrinologist. So it is going to be a teamwork there. Do not try to do anything all on your own. And usually the infusion pump, that infusion catheter is there, no, that will be changed every 3rd day. So find out when last the catheter has been removed.
Yes.
Then 24 hours before the surgery, you position the cannula to a new site. Position it to a new site. Then intraoperatively, you have got two options. Either the insulin pump will provide one basal infusion rate, and then bolus doses whenever required, for example, after a meal or something like that. So intraoperatively, you have two options now. Either you maintain the basal infusion rate or you decrease the basal infusion rate to 80%. Or you don't change the basal rate, just maintain the normal basal rate. And if there is hypoglycemia, you give exogenous glucose. Okay, and try to schedule the patient early in the morning. And if there is any problem, you should know how to turn off the pump or how to pause the basal infusion of the infusion rate of the infusion pump. And don't forget to place the pump far away from the electrocautery, because electrocautery can disturb the functioning of the pump. So it is similar to a pacemaker device. I think you know how to anesthetize in a patient with a pacemaker device. So similarly, it is like that. And I think that's it about the pump.
Yeah.
Okay, thank you.
Thank you, ma'am.
Any more questions from the audience? Any doubts you have regarding the case?
Dr. Pooja, one thing I would like to add at this moment, Naveen sir has very rightly pointed out about the choice of regional anesthesia, and he was arguing about the ketone bodies. So actually, what the emphasis of management of diabetic ketoacidosis is that you should also treat the underlying cause. You cannot avoid treating the underlying cause and go on for treating the diabetic ketoacidosis like you are trying to correct the blood sugar, the bicarb, and the taking care of the acidosis or the ketone bodies. The underlying cause has also to be taken care of, and that is very important.
Yes.
So that is what I think he was trying to emphasize simultaneously on that point. And yes, definitely a decreasing ketone bodies will mark that the patient can be taken up for an emergency surgery.
Yes, sir.
Yeah, Vishal, that was the concern that Pooja, if things start settling, remove the cause. Otherwise, it will further lead on to hyperglycemia. Same way, 80 years old female and blood sugars of 300 milligrams. Coming for cataract surgery under surface anesthesia. A young budding ophthalmologist wants to do the cataract surgery under surface anesthesia. What will be your advice?
Sir,
he asked you, Dr. Pooja, aapne to acha viva diya hai. You have answered so well in the exam, and Dr. Madhuri was about to give you extra marks for insulin pump. So what is your opinion on that?
Sir, if the blood sugar level is more than 300 milligram per dl, so that means that the patient is hyperglycemic. So the HbA1c value will be definitely more than 8.1. 5. Sorry.
Surface anesthesia में cataract is, I am going to do the cataract surgery under surface anesthesia.
So, but still it will hamper the healing of the.
Why? What will you teach him?
So I'll teach him to decrease the blood glucose, to optimize the patient first, and then
Well, he will ask why, Dr. Pooja, you want, what will happen?
because it will again lead to it will impair, first of all it will impair with the wound healing. It will impair, it will lead to there will be increased rate of infection.
Yes,
Chances of infection.
Yes, sir, this is nothing related to anesthesia. You can do it under, if it's emergency surgery, if it is gut gangrene, I'll operate at 500 sugar levels also. No worries. But this is your surgery where your surgery will fail because of the infection in the postoperative period. You will be using certain local steroids also.
Yes, sir.
And that may further increase the blood
Aggravate the
levels.
problem.
It is better to go for that. So, okay,
Yes.
thank you, Dr. Pooja, for this advice. I'll take up this patient after 2 weeks or so when the blood sugar level. It's not an emergency surgery.
Okay, sir.
Okay. Over to you, Dr. Bajpa.
That's a good one. I didn't ask a single question of mine, though there were so many revolving. But at this level, at the level of a second year, if you are confident the way she was answering, the way Pooja was answering, everybody should take a cue from that. And whenever you don't know anything, don't answer. Just, I think that will also fetch you marks. Examiner will see that if you make a blunder, he will definitely deduct. And if you are still silent, examiner knows more than you. That's for sure. And if you are not answering that particular high-pitched question, which he thinks if you would have answered, you would have got a gold medal. And if you are not answered, but at least you will not get negative marks for that. So that's the way to approach the examination. So in these classes, the main aim is to how to get through these examinations. Now the examination should be there. It's not about just one knowledge and just vomiting whatever we have learned in our PG years. So it's about the attitude as well as the conduct of yourself, how you really answer. And Dr. Madhuri is also a very hard taskmaster, and that's why whatever she is, if you can answer her question, you can easily pass. That I'm sure of. But really good show by Dr. Jitesh and Dr. Vishal Weber. They have done a wonderfully good job. And it's not about only the professors. I think the youngsters also are very good teachers. That's why they're assistant professors, but they are very dynamic. They are very good teachers. So the whole idea of these PG classes is the upbringing of the good teachers. It's not about the age and experience also. Sometimes the good teachers are young teachers also, and good students can be second year students also. Our focus will be on first year, but that is little difficult. But from second year onward, if you are answering good, that's the way to go. So wonderfully done, Pooja. I'm really proud of you that you did everything in a very calm and composed manner. That's the way to do it. I'm really thankful to Dr. Jitesh and Dr. Vishal Weber. They did a wonderfully good job in carrying out all the questions which are relevant for the examination to be conducted in the final session. And this, I think, next class we will be having on the thyroid cases. So thyroid is also another important surgery, I think, where anesthetic management becomes extreme. So to the extreme of things, we can go to that. But today, I'm really thankful for the team from Patna Medical College and AIIMS Patna. And I just want to give over to Dr. Jyosna so she can close the present day thing. And if before that, if anybody wants to give more inputs, they can raise their hands or they can unmute themselves to say about this class or about the upcoming classes, the feedback for the upcoming classes. You can raise your hand and you can go ahead. Otherwise, Dr. Jyosna will overtake from here.
Okay, please give inputs, any questions, any inputs you want to give, everybody.
I think we should hear from Vishal and Jitesh also, at least two, three liners from them, both of them. Non-questioning things.
So I would like to say that per se diabetes mellitus is a bit extensive topic. So covering the entire topic in just 1 hour, I think we can just go for like complications of diabetes we can take up as one case, and the management part in a different case. That would have been more elaborative for the other students as well.
No, definitely. This was kept as a long case. The short cases will be coming. Diabetes, 2 cases on the same day we can keep till the examinations of the postgraduate students are over in the entire country. So we can go with the case presentations also only.
Here, the
That
idea was to do actual
uh,
case presentation, how it happens in the exam. That is
yeah,
why
yeah.
that.
Let's because examination period will be starting from the mid-May to late May, then we can continue up to July in different parts of the country. So let that period be over. After
Okay.
that, we will go to regular classes as well as case presentation, and we were thinking of having a panel discussion of teachers also during Monday classes, or maybe having on a Friday a panel discussion, maybe fortnightly. That you can throw a good light. It will be just a mixture of case discussion, class-based discussion, everything. In panel
Okay.
discussion, we can cover that. Dr. Jitesh, you say something, then after you, Dr. Madhuri will, I think, will also
Okay,
say.
sir. Oh, thank you very much, sir. Oh, actually, Pooja has prepared more than he delivered. Actually, uh, I would like to thank Pooja. Uh, uh, he answered most of the questions very well, and
Yeah.
I would like to thank you, sir, for giving me us opportunity for this.
Really, you all three did well, and
Thank you, sir.
Pooja did exceptionally well. Dr. Madhuri, you want to say something
Yeah,
again?
I just want to tell the students here that diabetes case can come either as long case or short case. It all depends on what cases the examiners get on the day of the examination. So it often comes as a long case, but it can also come as a short case. So as a short case, it usually comes as diabetic foot. So you be ready for a diabetic foot and be ready for all questions on regional blocks, especially all kinds of nerve blocks for the lower limb. You be ready because it comes as a case of diabetic foot. So don't just think about insulin doses and how to adjust insulin dose. Many of the times the examiners never reach up to that level of insulin dose and all. We start with the pathophysiology and then go on to regional blocks. So this is what I would like to advise the students. Thank you.
Fair enough.
Pooja, you did really well. For
Thank you.
second, I think you were very well prepared and you could take the pressure of, so many people actually asking you so many questions apart from the moderators as well.
Yes.
And the moderators, you covered the topic very well. So congratulations, Pooja, and all
Thank
the
you.
best.
Thank you.
And
So I think it's a time to say goodbye, Josna.
yes, sir.
So we will meet next week with a case of thyroid, and that will be presented by again a third year PG student this time. So we will meet next time, next week, same time, 6:30 p.m. Till then, it's a goodbye from national headquarters, and thank you everyone for joining this class. And in the end, we say long live ISA.